it's hard to believe that it's AWE 2026. Dr. Yap and I have been doing this for more years than we could count. It's hard to believe it's our 9th year together. First of all, I want to say thank you.
Thank you.
For support and having our back always. It means a lot. But today, Dr. Yap is the head of everything important in GI and Kaiser. And he's going to talk today about an important new technology, which is full FTRD. And he's going to tell us all the tips and tricks of how we need to do it. Please.
Thank you so much, Dr. Riker. First, I would like to thank AWE, Dr. Riker, Dr. Nguyen, Dr. Krinsky for inviting me to come and share with you the technique of full thickness colon polyp resection. I think that as those of us who, as advanced endoscopists who perform EMR, even in best hands, we do have a certain percentage of recurrence. And these recurrence can be very challenging, especially in the background of area that we've already did the snap polypectomy, cauterization, and therefore we are no longer able to lift the polyp off the surface of the colon to be able to safely remove it with additional EMR or ESD. So I think this technique is a good rescue technique for those lesions that are recurring and we're not able to take it off in a standard approach of EMR or ESD. Now, the second indication I think that's worthwhile to also discuss are patients with early colon cancer, especially if it meets all the favorable basically indicators, well differentiated, no different vascular invasion, etc. And also, of course, patients are considered high surgical risk. Those are also the patients that have been sent to me or to our Center of Excellence in Orange County to do the full thickness resection. And of course, last but not least, the group of patients with submucosal lesions that can be difficult by a standard endoscopic technique, and by using the full thickness, we're able to address those lesions, whether it's in the stomach, duodenum, or colon, or rectum, okay? So as far as the procedure itself, the scope, we use a therapeutic scope. We use the Ovesco full thickness resection kit that comes with essentially the cap that we already attached to the tip of the scope. And then subsequently, the technology is very similar to banding. I think all of us who have done banding in our general, GI, training definitely are familiar with this technique, having basically essentially a knob with a string attached to allow us to be able to deploy the clip. So before we even started the procedure, the key thing is the preparation. Make sure that the cap, the device is fully and accurately and attached to the scope in such a way that would allow us to be able to drive the scope to the lesion of interest. Now, for example, most of the time that we're doing this is in colon lesions. And by statistic, it's going to be an ascending colon. So to drive the scope, right, with the cap attached to the tip of the scope can be quite challenging at times, especially for us to negotiate around the rectosigmoid junction.
How do we, so tell us, when you're in that situation, how do you solve that problem?
You're right. So the first thing is that, as you know, the first part of the procedure, I know for this demonstration, we've already did the marking here, but for the actual procedure, I use two different scopes. So the first scope, we basically allow us to drive to the lesion. So I make a guesstimation as to how difficult it is to negotiate around that rectosigmoid junction. If you feel that with a standard scope you're able to drive there relatively safe, I think for the most part, the success will be helpful.
Do you use that trial cap?
Yeah.
Please tell us about
However,
that.
when you put the scope and you have already a difficult time negotiating a rectosigmoid junction, then the Ovesco do have essentially the test cap that you can attach on to see whether you can negotiate around that turn. However, that's why I've also tell my fellows and trainees, the struggle to get that cap, to get past that junction, I would rather use that time to actually negotiate the real cap that's already attached on. So in reality, even though they have the cap, I don't really try to struggle, because if you struggle so hard just to get the cap through, and then later on you're going to struggle again with the real device, I would rather just basically try the real device in order to avert the additional risk.
That's why we do those recordings, because that's how we learn from the masters.
Yes.
Okay, I'll forget the cap. Sorry, Riley. Yeah. Let's keep going.
Yeah. And in addition, this is the part that's important. As you can see, the scope itself have an additional sheath, plastic sheath. So again, to negotiate the scope to the ascending colon can be challenging. That's why an assistant having a loop tube constantly lubricating the shaft of the scope as we advance the scope. It's going to make us much easier to negotiate, past the rectum and get to the lesion as well. Okay. Now, once you get to the lesion itself, this is the critical part, that you have to mark the lesion itself, because as you can see, the visualization is significantly impaired because of the cap that's attached to the tip of the scope. So there are many times when, at least on initial endoscopy, you found a lesion so easily. You think it would be so easy for us to negotiate and get the scope there and find a lesion. In reality, once you attach the tip of the scope, the orientation of lesion itself can also change. And so sometimes some of these lesions are very difficult to find again. So on a really difficult lesion, I even make it a point, especially in lesion of suspected potential early cancer, to also tattoo more distal to it or even clip it. So that way it allows additional markers for you to use you to guide to get there. And sometimes you have stool obscuring the view. So I think the visualization is very important for us to mark, make sure that we can get there, and make sure that we can find it when we get there.
And
so,
the way you mark, isn't it different? Because then, let's say what you would do for ESD or even AMR, how is it different?
Yes. So as far as the marking itself, well, this up here, I'm going to demonstrate it here. The lesion itself, for example, let's make a lesion a 1.5 centimeters. The cap itself can only accommodate roughly about 3 centimeter lesion at most, right? And you also want to make sure you have good margins. So in reality, I think most lesions, I would say, up to about 2 centimeters, you can reliably use this technique to assure that you also have the mucosa margin. The depth margin, once you got full thickness, it's pretty much a guarantee you get a deep margin. But the lateral margin, you ought to make sure that you have good mucosa margin. So as Dr. Reiko, basically make a reference earlier, you make sure that you mark the spot outside of that area of the margin, so that when you get there, when you pull later on I will demonstrate, once you pull the lesion itself into the cap, you are able to see all those markings, because that assures you that you have the lesion at hand, okay? So that's why it's important that you make sure that you get good marking. For example, in this example, of course this is the pig stomach, so the marking is not going to look as beautiful in real lesion, but I try.
So you're a perfectionist.
Yeah, to make sure that you got the suction is a little on the low side, so I'm going to wait for that be able to lose. But anyway, the concept is that you're trying to mark the lesion at the full circumference, so that way when you pull the lesion in itself, you also assure that you have the whole lesion within the cap itself. The next trick also, some of these lesions can be very friable.
Yes.
Right? And so if you use the rat tooth, once we get there, and we use the rat tooth and pull it in, once you grab the lesion itself, the tissue actually can fall apart.
Separate.
Exactly.
Yes. So what do you do?
There you go. So one of the tricks, okay, so why don't we put the grasper down to demonstrate that technique?
And do you typically use the grasper that comes in the kit?
Correct, that's right. Yeah, so I basically routinely use the grasper that comes with the kit. The reason being this, similar to rat tooth, it actually have I'll demonstrate it right now.
It opens wide,
very
right?
wide, a very wide opening. And also another trick, and you can see here, as you can advance the rat tooth or device, you got to make sure that the string is basically straight and taut. You do not want the string itself to get entangled within the rat tooth itself or the marking catheter. So I always make sure that the string itself is always straight, because if you had a loop and you advance this out and it loops around the string, you basically more or less have just basically tied that
yourself in knots.
Exactly,
yes.
And you won't be able to put it in. For example, so let's use this as an example. And just make an example that this is the lesion itself right here, okay? And then I go down here, let's make an example. This is the lesion here, and it's very friable.
Yes.
I actually don't grab directly onto the lesion, because the tissue is just going to be falling apart and it's going to separate. So I move over to the lateral side where you have actually normal mucosa.
So you grab the normal mucosa next to
right
it.
Next to the lesion.
Oh, wow.
Open the rat tooth right here for me.
I've been doing it all wrong for a while now.
Yeah.
Okay.
For example, the reason being is that the normal tissue you're able to grab, close the grasper right here, you're able to grab normal tissue. But more importantly, with the grasper being big enough, you're also able to grab all the way to the muscle layers. So you have a very good pull. And therefore, it's less likely, because now it's normal tissue, it's less likely to fall apart on you, right? So that's why, especially for lesions that are friable. And then the next is that, this is the key, is that you have your assistant making sure the grasper is constantly on a tight, basically closed position, and then you pull the lesion itself onto the cap. Sometimes you do have to negotiate, right, the tip of the scope to make sure that the lesion itself go into the cap like this. And you look, right, you make sure that the marking that you did earlier should be around here to know that you have a clear margin of the lesion itself that you're going to do a full thickness resection on. Of course, Riley will yell at me if I were to tell you to use some suction, because their formal instruction is not to use any suction at all. But okay, this is
Riley, close your innocent ears.
This is just my experience for the last 6 or 7 years doing this. You do have to use a little bit of gentle suction to make sure that the lesion itself nicely fit within the cap, right? Afterwards, then it's important, if you look at my hand, I make sure that the grasper itself, rat tooth here, are tightly held by my finger. Because we want to make sure that you have this constant tension. Because once you deploy the clip, right?
Shall we do it now?
Yes. Once you deploy the clip, sometimes it moves away from you.
It jumps so far.
There you go.
So what do you do?
There you go. So I constantly pull it with this hand as I deploy the clip.
And do you push the scope in sometimes?
There you go. So that's why you did. That's right. I do this to make sure that I got a good lesion, stay in a very fixed position. I hold it up even further.
And thank God you have Monica here. She is holding it.
Yes.
Oh,
and then, of course, deploying this is very similar to deploying a banding, right?
Oh, look how nice
and then you basically deploy the clip. So that is when the clip is done, right? But this is the part, the next part is also very critical. I tell my assistant never to remove this protective, basically, sheath right here, because you don't inadvertently basically deploy the clip. So now that we have deployed the clip, then we put the active cord on.
And one of the big advantages of this device, it's very fast.
That's right, it's very fast. And then you remove the protective sheath here. And then I'm gonna have Monica.
It never breaks.
There you go.
There you go.
Close the snare, okay? So this is actually a mistake that I have made in the early years, is that I basically step on the pedal before the assistant barely start to close the snare. That is when you potentially can literally burn the plastic ring around it, and therefore the snare will not be able to close the lesion. So this is the important part. You ask your assistant then close the snare, and then once it's on the closed position, then you step on the basically the endo cut and close all the way, Monica. There you go.
Yeah,
as you can see, it goes up pretty quickly. But the key part is that you make sure your assistant start closing the snare, right? I would say close to almost the lesion itself, and then before you step on the electric cautery to make sure that it completely snare off.
And then, you're done.
You're done. And then you subsequently take of course, the active cord off, you pull the lesion out, and then you put the lesion itself, you inspect it to make sure that you got all the margins onto essentially, we usually the styrofoam, and then we submit it to Pat, and then we go back in, inspect the site. And
so let's do that.
Yeah.
Or it might be a little bit hard. Maybe we can push it out and show the...
How about,
maybe we push it out.
Open the ratchet.
Uh-huh. That's a nice piece.
Yeah, that's a nice piece.
That's a nice piece. And then it doesn't want to part with us, huh?
There.
Yeah, here we go. And maybe we push it out a little bit.
Let me do this.
And then we can show the final product.
Yes.
Because the model is a little bit harder for us to advance the scope back in.
Yes.
Here you go.
Right, let's check that out.
Yeah, and you actually can see that already.
Yes.
You have a full thickness right there.
Right. And then when you go back down, you can see here the lesion itself
look at that.
has the clip around it. And on real live patient, of course, you can see the omental fat actually right at the center. On occasion, of course, you see a little bit of oozing at the margin, but the nice thing to having the marker is that you can use that for electrocautery. And honestly, just a little bit of oozing, you can easily bicap it with the marking device and be able to achieve hemostasis. And
wow, in 5 minutes, we learned so much from you. Thank you so much. That was a lot of tips. Grab the normal tissue. I definitely going to do that. And we are done. Thank you, everyone.
Thank you.
All right.